So, welcome to the Innovative Discovery Series. Thank you everyone for coming. We are honored and delighted today to have Dr. Hutchins giving us a talk about ethnographic research methods. But before I introduce our speaker, let me go over some housekeeping issues. For CME credit, you must sign in and must include your email and credentials. Next week, we'll have Neil Goldstein, who will talk about social and spatial correlates of infection in the NICU on March 31st. Then we have a tech talk on April 6th with Dr. Michaela Toffer from UD, who will speak on leveraging big data analytics to examine food nutrient content. And as always, the full schedule is posted on our website, DE-CTR.org. So again, I'm really delighted to introduce Dr. Hutchins. Sorry. So Dr. Hutchins is a practicing medical anthropologist and ethnographer, and she has a PhD in cultural anthropology from Temple University in Philadelphia. She has led multiple projects in the fields of health and medicine in Philadelphia, in Pennsylvania, but also abroad in Vietnam and Cambodia. Some of her local projects include a study of Americans' experience and attitudes pre-post soda tax, an evaluation of patient-centered approach to observation care and transitions home, and also patient-centered transition planning following discharge from the emergency department. All these projects we are really very interested in are extremely actual, and issues in our institution. She also has done several studies of health perceptions related to fracking in Pennsylvania, or evaluating the impact of community gardens on vulnerable populations, including post-conflict refugees. Some of her global health projects included a situational analysis of drug-using children in Vietnam that was funded by UNICEF, several projects in Cambodia to analyze health-seeking behaviors and understand problems associated with poorly funded healthcare, and also to develop a child-focused section of the handbook on the management of violence against women and children in health system, also funded by UNICEF, and many, many, many other projects. She has many publications, has made multiple presentations in national and international meetings, as well as multiple videos, and I'm very impressed. Thank you so much.
Hi, everybody. How's your lunch? Is it tasty? Oh, no?
It's too good to respond.
Hello, everybody at home or wherever you might be. So you heard a little bit about me. Thank you for that nice introduction. I appreciate it. I guess I'll just go ahead and get started. Just some pertinent information. I don't have any relevant financial conflicts of interest. Dr. Kristen Rising at Thomas Jefferson University Hospital in the Department of in the Emergency Department is the principal investigator for this research, and the study was funded by a grant from the Emergency Medicine Foundation and awarded to Kristen Rising, Judd Hollander, and Brendan Carr. So, some of the goals of the talk today. I don't really know how familiar folks are with anthropology and social science research in healthcare settings, so I think it's important just to give you a primer on what anthropology is and what medical anthropology is. So I want to also clarify how this anthropological approach helped us learn things that we didn't know about fear in the emergency room. I think it's interesting to think of knowledge as there's all the things that you know, and there's all the things that you know that you don't know. But there's this whole body of knowledge of things that you don't know that you don't know. And I know Rumsfeld said that, but forget him, okay? But it's a foundation in anthropology is to help clear out those blind spots so that you can solve problems. So another goal of the talk is to convey the agency and structural constraints that influence the choices that the research subject made. I'll be talking about a particular case study, and put those in the construct of what is inappropriate emergency care and what is appropriate emergency care. I also want to talk about the importance of what we call structural competency for helping providers develop that concept within their own practice, and also to help hospital administrators and institutions develop that as well. And finally, to advance healthcare solutions that can enable people to seek the care that they need that is realistic. So this is a bit of an outline. So I'll start with an introduction to Hank Jones. That's a pseudonym for the case study discussed in the research. And then I'll go on to a primer of anthropology. Who has ever taken an anthropology class before? All right. Oh, that's a nice ratio. Good. Okay, good. Talk a little bit about what medical anthropology is, talk about the research project, how I applied the perspectives of medical anthropology to the data, and then I want to focus in on the case study so that you can understand some of the things that he's talking about and how they showed up in other studies that I've worked on with Dr. Rising, and how we can kind of analyze those socially. How I talk about fear, what is fear even? I'm not talking about fear of spiders, and then delve into structural competency, and then go to recommendations. So that should give you sort of a roadmap to the talk. And I'm going to try to stick to a 45 minute time. So I wanted to talk about Hank Jones first so that you can have a person to attach all of this information to. So he's somebody who might be characterized as a misuser of the emergency medical system because he'd gone to the emergency room twice for headaches. He'd started having headaches about 3 years prior to meeting him. And he's a 52-year-old African-American man. He has a history of stroke in his family. At the beginning of the study, he was insured when we met him, but the conversation that I had with him refers to times when he was uninsured, low socioeconomic status, and unprompted in his interview talked about fear. And so he said to me, well, we sat in his row home that was in a housing project in Philadelphia. It was like right on the interstate, 100 feet from the interstate. You could smell the traffic, you could hear the traffic. And, he talked to me about his mother, his grandmother, and his aunt all dying of a stroke. And his fear that he was also going to die of a stroke. But also why he would not, how fear kept him from getting care for a period of time, and then how fear helped push him to get care. He's, talked about his life as a kid. He talked about how physical he had been, and then now here he's 50, he had an accident at work, couldn't work, and he's like, I thought you still got the perk at 50, but he felt like he's just falling apart. So he was incredibly generous with his time and with his experience, and I just want to do every honor to him, and so I wanted to introduce you to him. I wish he were here. I tried to follow up with him to have him approve this, how I characterized him, but I couldn't find him. He was not there. So let's just, in case it's been 10 years since you've had any anthropology or you never have, I just want to introduce you to some of the fundamental concepts that shape how I practice anthropology. So we always go by sort of the framework of cultural relativity, where you recognize your own cultural practices and you recognize your own cultural values and what you think is beautiful, what you think is right, what you think is moral, and you set that aside. And you let the other culture emerge, right? So this exists in opposition to ethnocentrism, right here. And it exists within attention to human rights, because certainly we want to say, well, that's your culture to stone people to death, so that's fine. So not saying that, but you don't want to judge by your own cultural standards. We also practice holism. you can't just isolate a problem and look at it without having an awareness of all the different layers, the different contexts that intersect with that particular problem. So you have to look at a problem in its context, and so you can't just look at health and one particular health problem from an anthropological perspective. You need to look at it within the healthcare system, within family, within society, and all the aspects of society and all the aspects of family that that person lives in and experiences. Also, we recognize culture. Of course, culture is learned, it's shared, it's patterned, it's adaptive, also maladaptive. Hello, McDonald's. And it's symbolic. So everything from language to what you choose to wear to how you express yourself, the car you drive, all these different symbols that are around us all the time. Those are all important. So I'm going to talk now about 3 enduring questions that frame a lot of anthropological work, including medical anthropology. One is structure versus agency. So agency, you could understand as a person's capacity for free will, their rationality to exercise choice or initiate acts. That your individual free will, from an anthropological perspective, is constrained by structures that exist in society. So norms that reduce individuals' ability to exert agency. We're always, in anthropology, we're always saying, like, well, to what degree is there individual agency? Where does structure take place? How do you navigate that? You can't say that somebody has 0 agency. You also can't say that somebody has 100% agency, even though it's a cultural standard in the U.S. to think that one's agency is what makes things happen. Another enduring question is, when conducting research, how much should you prioritize the researcher's perspective and frameworks or the etic perspective? And how much should you prioritize the insider's perspective? The insider being the insider to culture, the insider to that framework. So that's really important, and I think that this picture kind of illustrates it. Right? Here's an etic explanation of, obviously, I guess, a group of indigenous people. What people ate. How old is it? People didn't sit around and say, what do we eat? They're like, I love this. You want to try it? So, what is their value? So that's always important. And then the last thing about these anthropological approaches is micro and macro. So micro is the individual, the household, the local level. Macro is these large-scale social processes or forces, like government, national policy, history, economic opportunities, concepts of race, concepts of social class, concepts of gender. And so, again, we're looking at how does the individual on a micro level affect the macro level of society, and how does the macro level of society affect the individual? It sort of has some resonance with structure and agency. So that's your primer on anthropology. Good? All right, so we use qualitative research methods. We take an inductive approach. We never do experiments on anybody. We practice ethnographic research, which usually is time-consuming. It's trying to get at some of those enduring questions that I just discussed. We use participant observation, visual methods, including photo voice and ethnographic film, participatory research, interviews, focus groups, and any sort of creative way that you can think of to gather information. So this is in Cambodia. I was doing research on, how do doctors understand kids who've been sexually abused, but I needed to first understand how they understood, sexual abuse. How do they talk to their patients? How do they, figure out what's wrong? And so it's interesting that so many people are illiterate, so they use pictures to convey, health messages. And so it's sort of interesting. So you learn a lot about what you don't know that you don't know by using these qualitative methods. So we try to apply all of this knowledge to problems that are social in nature. We collaborate with other disciplines, and we try to understand that as people talk about their lives, they might not necessarily talk about these bigger structures, but as an anthropologist, you're trained to recognize that those exist, and that's part of your research. So now to medical anthropology. What is medical anthropology? It's a subfield of biological and cultural anthropology. Anthropology has 4 subfields: biological, cultural, linguistic, and archaeology. So a lot of people think, oh, Indiana Jones, when they hear anthropology, and I'm here saying, no, think people alive walking around saying, hey, how's it going? I feel good. Or I don't. Yeah, you get my message. So a starting premise of medical anthropology is that health-related issues, including disease and treatment, are far more than narrow biological phenomenon. How we get sick, why we get sick, what sickness means to us, are all heavily determined by cultural and social factors. And the same is true about what makes us get better, how diseases are understood and handled by healthcare providers, and how illness is experienced by the person who is ill. So different practitioners, different scholars cover different areas, but in general, it's really studying how medicine is practiced, whether you're a traditional healer or someone in the Unani system of humoral medicine, or you practice traditional Chinese medicine, or you practice cosmopolitan biomedicine, like probably you and I are familiar with and have experienced most. We studied the experience of what it's like to be sick, and it's the application of cultural knowledge to the actual treatment of diseases. Here, I think this is interesting, the different scales of medication, and, of course, they represent, you can't remove these from the economic context in which they exist. Certainly in an industrial, post-industrial capitalist environment, you're going to have, conveyor belts of pills going to all the masses, and here you have individuals preparing herbs carefully, and so you have different scales of treatment. Another focus, lastly, is the study of folk illnesses in different societies, like susto, for instance, or fright. And so because health and illness and treatment can't really be understood just from a biological, physical perspective, you need to incorporate more of a social perspective. So if you take Ebola, for instance, is it enough to know how to solve the problem, from a curative standpoint? Would that were the case, right? Would that even existed? But you would also need to know, if you were engaged in treating people with Ebola, you'd need to know, how do people understand death? How do people interpret, biomedicine? Are they afraid of biomedicine? What do they know about biomedicine? How do people handle bodies? What are funerary practices? And you could ask all sorts of similar questions, whether it's about AIDS, about leprosy, or about people's use of the emergency room. So now that that's all clear, let's go through. But I feel like I needed to do that because I don't know if you would, this might seem like anecdotal information rather than a systematic examination of the micro related to the macro. And I think that misinformation or that missing perspective on part of people who don't have any experience in social sciences can diminish the valuation of social science research because people they think it's oh, it's not deductive, or oh, it's not quantitative, or it's not, people are just saying stuff. Well, yeah, they are, but. All right, so articles have come out of this research. I'm just a patient, fear and uncertainty as drivers of emergency department use in patients with chronic disease. And that was really focused on the hospital-based research where we did 40 interviews with patients who were ready to be discharged from the emergency room to understand what they needed. And this article, Fear, Vulnerability, and Sacrifice, Drivers of Emergency Department Use and Implications for Policy, that's mostly what I'm concentrating on today. But it was done concurrent with this, and it was based on home interviews with people who had participated in the study and consented to home interviews. So my collaborator and I, Dr. Rising, we wrote these within the sort of the research context of every year there's 350 million annual visits to acute care centers. I'm sure that changes over time. There's also really a vibrant discourse about shortage and people overusing medical care, or overusing, I should say, emergency care. There's also takes place within the context of the fines imposed on hospitals for readmissions for some cases. I'm sure you're all familiar with these constraints and these ways of talking about it. So some patients within this, patients then get constructed as like seeking care inappropriately, or seeking unnecessary care, or overusing or misusing emergency systems. And there's certainly a financial incentive to keep that from happening. So the question that is an etic question, right? So this is Dr. Rising's question: how can the acute care delivery system be redesigned to be more patient-centered? And so to answer that question, we really tried to engage with patients who had been discharged from the emergency room to explore with them how they thought that, components of the hospital could be reinvented to fit their needs. We wanted to identify what are their primary goals and needs during their emergency room visit, and to kind of explore what they might need as they transition back home. So a little bit about the selection of participants. All patients had a history of diabetes mellitus or cardiovascular disease, and this allowed us to have a broad range of patients with varying experience with the hospital system. So a little, just an elaboration of what I just said: 40 interviews at 2 different hospitals in the Philadelphia system. One is an academic teaching hospital, the other is affiliated, but it's a community hospital. And then follow-up interviews. So the follow-up interviews, they were, rather than questions, they were topics. And we just sat and talked 45 minutes to 3 hours, depending on how much people wanted to say or had to say. Topics included what are their familial patterns of healthcare use? What is the history of medical care? How important is health relative to other aspects of life? Because we tend to assume, like, well, of course health is most important. But if you have other things that are calling your attention or tugging at your pocket, then it might not necessarily be the case. EMIC characterizations of the emergency department and challenges with aftercare. So it was interesting, in the hospital interviews, we didn't seek to interview people about fear, but that showed up a lot. People were really talking a lot about fear, about uncertainty, and in the interviews with people at home, I didn't bring up fear, but 2 people talked about fear, and Hank Jones was one, and another was a wealthy woman who talked about the way her upbringing had really helped her overcome her fear. And I thought it was so interesting that she was able to talk about, just like sitting in this beautiful home, and she was so generous, she was so kind, and, she talked about how her upbringing had made her think, like, if I need it, I'm going to get it. And I'm not going to sit back and wait for somebody to give it to me. I'm going to get it. I'm not going to deny it to anybody else. I'm not going to step on anybody to get it, but I'm going to get what I need. And talking to Mr. Jones and just hearing about, his mother died, his aunt died. He's afraid to go to the hospital because then he might learn that he's about to die too. And so his fear really, his experience with health and healthcare made him fearful. So that's kind of the, with all that information, so what? What do you do with that? So filtering all that through a perspective of medical anthropology, I wanted to understand how we can understand people's fear. How do those narratives of fear intersect with participants' social locations And how does that also intersect with this idea of misuse and overuse? So the wealthy woman talked about how much she had used all this medical care, but she used it in the proper setting. Whereas, Mr. Jones talked about, like, I've used this, but I need more, but I don't, I don't have insurance and I'm scared. And so how do these, what is the intersection here? What are the structures at play that shape the emergency department interactions? There's the culture of biomedicine, there's doctor-patient power dynamics, there's patient subjectivity, which is all over the map. And who are these emergency department patients? Besides their demographics, what are some of the nuts and bolts of who they are, and not only the nuts and the bolts, which sounds structural, but also like the details, the nuances of who they are. And so how can I apply cultural knowledge of interviewees to the emergency department encounter? So that was hard in an EDIC kind of setting where, the questions are very scripted and they want to know, from an emergency perspective, what can we do to help you? When people didn't necessarily know even what the emergency room was about, and so, of course, I have no way to answer those questions. So we first met Mr. Jones at the emergency room after he'd taken a bus across town to come to the emergency department with his fiancée for an evaluation of another severe headache on the left side of the head. And this visit had followed previous emergency department visits, a primary health care visit, and an appointment with a specialist. All of those took place when he was uninsured. He was insured when we met him. So during the interview in his home, he discussed, like I said, how his mother, his aunt, and his grandmother had all succumbed to strokes, and how his fear of sharing the same fate kept him from getting care when he didn't have insurance, and it drove him to get care when he did. In both of these instances, fear was the motivator, but his vulnerability shifted when he was insured. He talked to me about his upbringing, about, being raised in a woman-centered household, having a mentor that helped him, develop a love for gymnastics, for track. He talked about his mom. He said she was a super mom. You know what I mean? So yeah, that's why I was trying to be a super grandpa or a super dad. I tried to be different I tried to be in my kid's life from the day they came out of the womb. So during his interview, he constantly made reference to his family, his daughters. He showed me this tattoo of his, different daughters' tattoos on his arm. His granddaughter was there playing. Another granddaughter came home from school, and he spoke with such love about all of his family. It was great. In his interview, I asked him to reflect on his medical history and what were the particular events that stood out to him and the medical care that he got as a child. What happened with his mother? What happened? What were things that he remembered? I wanted to know what had happened so I could understand how he and others that I interviewed interpreted the care that they sought and the care that they got. I wanted to know what their relationship was to the medical system. So, of course, we know that people in poverty, so talking about some of the structural forces that affect care, people in poverty are less likely, less able, or delayed in getting care. You can look at some statistics of men in Philadelphia, and you see that African American men just have, it's harder. It's, they have less coverage, their life expectancy is shorter. There's a lot of different things going on that make life tough. Of course, not for everybody who's African American man, but statistically. There's also some of the structural forces that affect care. I'm sure you're aware of these historical violations of human rights and dignity of African Americans by healthcare providers. And this has a lingering effect on how people seek health. Certainly Jim Crow laws in the South and elsewhere had an effect on who got care and where and what type of care. So all of these are sort of historical factors that affect people today. And, you know, look at how he characterizes his world, how he characterizes his friends, right? They're dropping like flies. So, you know, another structural force, of course, that he is uninsured. And he has this fear of imposing a financial burden on his family if he were to die. So he avoids care. You know, he says, I didn't go. I got scared. I didn't want to hear that I've got something in my head and all, so I didn't go. It's the fear of knowing what's really wrong with you, but also the fear that once you find out, you won't be able to take care of your family. But then once he got insurance, his fear of abandoning his family if he were to die, like his grandmother, his aunt had, his mother. So that fear makes him seek care. He says, well, if I don't get my health together, I ain't going to be able to deal with any of it. Like I said, if I can't help my family, it's like I let them down. You know what I'm saying? So I have to work on my health so it can't destroy me. So if I fall out, I'll feel like I failed them. You know what I mean? So his agency, his ability to make choices is, with insurance, you know, he has more of an ability to make choices. And he makes those choices to go to the emergency room out of a desire to care for his family, a desire to be there when, you know, when his grandchildren grow up, and for his daughters, for his fiancée. He wants to live a full life, of course. So these are the things that are at stake for him. So if you look at fear, let's look at it for a second from more of a philosophical perspective. Gordon talks about it. Let's look at it from an anthropological perspective. So social forces can influence and produce this symptoms, right? That's fairly well known, I think. High blood pressure, etc. Some of these same social forces can also create feelings of vulnerability and fear among patients. So what is fear? You know, it's an interesting contradiction that when Mr. Jones didn't have insurance, his fear was of learning something was wrong. When he did have insurance, his fear was of not learning about a problem in time to solve it. But at the heart of that was always his family that was what's vulnerable. So Robert Gordon differentiates between fear or fears, like fear of spiders, fear of heights, the evidence or reasons for the fears, like, oh, they might bite me, I might, you know, and the attitudes a person has about the foreseen consequences were that to come true, that fear to come true. But one is really motivated to avoid the outcomes that makes one vulnerable. So it's not necessarily that people are afraid, it's that they're practicing sort of vulnerability avoidance. And action is taken such that if one's fears come true, one will have salvaged what is importantly at stake. So by, you know, he has these different fears, they lead to different actions, or he has the same fear but under different constraints, and they lead to, you know, different actions about pursuing his health, because the vulnerability is really his family and his ability to be there for his family. So, you know, when he doesn't seek care, it's almost this lifeboat ethics approach of sacrificing himself, persevering despite the pain, not seeking care so as to avoid imposing a financial burden on his family. And this all reflects his moral universe. Far different from somebody who's like, oh, he uses the medical system too much. So while his fears may not have anything at all to do with his actual medical condition, nor with his mother's, it's his perspective that they're related that's relevant here. And it's the part of the story he tells himself about his life and what guides his behavior. So what is structural competency? It's basically developing among practitioners and among administrators the knowledge that these social forces matter, that they make a difference in how people seek care, whether they seek care, when they seek care. And it's not a touchy-feely kind of, oh, they're so nice and they understand. No, it's a systematic education provided in medical school, in some medical schools, of how, how these social forces that shape people's lives affect health. And it's an awareness of those. And it helps avoid some inattentional blindness that takes place. Where, as an anthropologist, to me, everything is data, right? I am sitting waiting to do interviews with patients, and I see how a doctor characterizes a patient. Or I'm sitting watching a doctor-patient reaction in our interview, and I'm like, he said that to her? Just an inattentional blindness that doesn't respect the dignity of the patient. And it's everybody makes mistakes, but it was just like, this is something that is so relevant and it's so important, but it's not, it's in those blind spots. It's in what we don't know that we don't know. And it comes out of practitioner social locations that are not challenged typically because of the position of authority that people are in who are those practitioners. So there's structural competency that's provided for practitioners, but I'm arguing that it's not enough to provide it to practitioners. So you get a new doctor at your hospital and they have this background, but they're entering a system that doesn't practice it. So I think that you need to implement this at the administration level. You need to incorporate this into patient interactions and into decisions that hospitals administrators make. It needs to be incorporated at every level. So just in case it's not clear what structural competency is, it's the learned ability of a provider or an institution to link clinical symptoms, attitudes, or diseases to upstream decisions about healthcare and food delivery systems, zoning laws, urban and rural infrastructures, internet connectivity, criminal justice, incarceration, transportation, right? Think of these big problems that seem like there's no solution. Well, you don't have to solve them, but you do have to be aware of them, and you have to meet people where they are, instead of like, I see people streaming into healthcare centers. Well, there's all these different cultures and experiences coming that represent these different social strata, and how equipped are hospitals and health centers to prepare or to, accommodate those differences. So this, I think I carry away. I care about this stuff. So if we were to, if a lightning bolt were to come down and be like, oh my God, I get it, it would really address the inattentional blindness about the roles that history, about identity has in shaping the relationships patients have to healthcare. Relationships that were created long before they walked through the door, if they will walk through the door. So recommendations. I recommend place-based care as opposed to a sole reliance on space-based and person-based care. What does that mean? So place-based care, well, let's start with actually space-based care. Space-based care is a doctor's office, a clinic, a hospital, and people come here for this. And when they come, they bring their body and they bring their checkbook, or they don't, or they bring some relatives, but you don't see them in the context that they live in. You miss all this social stuff that's going on. They're a case. Person-based care, and I'm not saying we should eliminate this, but I just think that a sole reliance on it is makes assumptions about efficacy and efficiency that might not be accurate. Person-based care is very similar. Just the person comes in, they have this problem, and they leave. They talk about this problem, and then each goes on their own way. So place-based care is focus on sort of a geographical scope of care, and there are, say, community health workers who work in this particular geographical location, and they are in tune with everything that's happening in this area. Especially, it might be appropriate in, low-income, burdened areas. So, place-based care really seeks to address the collective problems of families and communities at the local level, usually involving a focus on community strengthening. So a community health worker would be one that is situated in the context of the community where problems happen. I think of Mr. Jones saying his friends are dropping like flies. Well, a community health worker would be aware of what's going on in the community. It would be, more, well, I'll talk about their tasks in a second, but they would be part of the community that they serve. They could work collaboratively with the community, hearing from the community what they thought needed to happen. They could build on the assets of the neighborhood, build on existing knowledge of the community members, and really act as conduits between the community and the other healthcare institutions. This would be trained in hard skills of nursing, soft skills of problem solving, and they could tackle such problems as vaccinations. They could promote breastfeeding, make referrals, do house calls, talk about food security, urban agriculture. They could arrange things with senior citizens so they didn't fall off the map and feel so lonely and isolated, prevent lead poisoning, be violence interrupters, lead community exercise and recreation projects, all these things that would promote health. And they could really, facilitate some real health care for people who might not have the wherewithal to enter the health system in a so-called appropriate way. So, in closing, the fundamental dilemma really is that access to health care is not sufficient to address the extraordinary levels of problems like those that Mr. Jones experiences. To make health care truly accessible, you need to improve housing, employment, financial security, and these are really tall orders, right? You'd have to redo how cities are laid out. You'd have to redo transportation systems, education. I mean, it's crazy. But in the meantime, people are suffering, and there needs to be a bridge. And while people, for many people, the emergency department is where they go to address their fear. But there's all these big problems from the payer's perspective, and they, there's an unwillingness to recognize, or an inability to recognize that fear is rooted in much more than the unknown of a health condition. If it were, with the political will, with an awareness, with a sort of a grounding in structural competency, it would make a lot of sense to promote community health workers, to promote place-based care. But in the meantime, characterizing patients as either appropriate or inappropriate ED users ignores the social complexity and realities of patients that informs when and where they seek care. And if we were to develop policies that take patients' different subjectivities into consideration, it could really enable people to get the care that they need. And place-based care would do that. So just to, recap, hopefully you'll learn about anthropological concepts and methods, how medical anthropology works in the clinical setting, that fear and uncertainty are related to things that are critically at stake for the patient, and those things are all socially informed, and that structural competency is something that we can all develop, and doing so will help reveal blind spots and interstitial blindness that limits care. And thank you so much for inviting me. Thank you especially to Sarah Fay for facilitating this and putting up with my delayed response to some emails. Thank you. wanting to meet Quilla and Frida. Yes.
Oh, this is totally fabulous.
Oh,
I
thanks.
just loved it, and I really learned a ton. And I'd like to say it confirms things I already knew, but I knew some of this, but not enough. So it confirms, but educates also. So we talk a good game around here, at least sometimes, about the social determinants of health and meeting people where they are, and community and community engagement. But then we fall back on overutilization of the ED, and we fall back on worrying about what the hospital margin is to the exclusion of much else, and on and on and on. We worry more about the procedures that are done rather than helping patients. So it seems to me that we need more thorough dialogue about this. How do we do that? Where do we begin and where do we go?
Well, we're here today talking about it. That's a start. And I think that medical anthropology and medical sociology are becoming more and more part of medical education, medical school education, but not 100%. Like, I work at some institutions where their medical schools don't have that. It's not required, and like, oh no, we would never do that. Okay. I think it does have to happen at the institutional level in terms of medical schools, but that comes from the decisions of, deans, and so, situations like this help inform those people. But I'm not a health economist, and I don't, it's a big confusing maze to me of the whole funding situation, and you can't remove it from the politics. Like, is there a vote happening right now on insurance? It's difficult. These things are political, right? Because they're about people's identities, and identities are what make it possible for people to access this resource, or this resource, or not. So there has to be. I think that it has to be talked about in the language of power, right? In the language of who are the power brokers. So put things in their language. Talk about savings, right? If you reconfigured things, something like a community health system that wasn't the public health clinics, which in Philadelphia are reviled, people will go to the one out of their neighborhood because they're so stigmatized. So if there was a real, you could draw on those networks, but if you could talk about this, you could frame it as a way to save money, which I can't help but think that it would. Then, and if you, recognized in medical treatment that there's so much emphasis on these heroic forms of medicine, where, let's do some stem cell research and, inject it into this person, poof, we solved one person's problem. And there's maybe 50 other people in the U.S. who have this problem, right? Instead of focusing on major public health things, so if you shift what the focus is, what the focus of treatment, and but nobody's going to do that. That's so, you have whole advertising campaigns on. I listen to WHYY. We have the gammon ray knife. So what? I don't think I want to go there then. So, this way of talking it, so it's part of this discourse of elevating the status of healthcare, of it's better if it's more technologically complex and it's more expensive and it's more, it's heroic, instead of no, let's just, let's have some violence interruption. Let's talk about breastfeeding. Let's talk, let's do some playtime, and let's go have a garden. Oh, there is no grocery store in our neighborhood. Let's have a co-op. So. It's got to be some of that stuff going on. You had your hand up.
Yeah, one of the interesting things about the size of Delaware is that we have the ability to do things on a statewide level that other states might not. And we have an innovative experiment going on in Delaware now with the Delaware Center for Health Innovation in terms of how we can transform the way healthcare is delivered. Some of it is place-based. There's a committee called Healthy Neighborhoods, and the third Healthy Neighborhood is being set up where the social institutions of that particular zip code region is starting to come together in a neighborhood council in terms of how and what we need in our own neighborhoods. The clinical and the workforce and education committee is looking at how do we in Delaware license or certify community health workers? What would be the definition of that? There's a patient and consumer advisory committee of which I sit on. And the hospitals are involved in this, the qualified health center is involved in this. So it's sort of a grand experiment that's going on in Delaware at this point. What exactly will happen with that, we don't know, but it's this quasi private-public partnership that's happening at this point. I think we're in the going into the third year of that.
That is
right
really
now.
interesting. I'm going to explore that when I get home. That sounds fabulous, and I think that the size really is important. You know, making mention of the size of Delaware, I think that would be critical, because then you don't have all these geographically oriented vested interests.
The insurers are involved in this in terms
Yeah.
of payment models. I mean, it sort of goes the whole gamut.
That could change. That could be a game changer. It seems like, if it were to, you know, over time, develop and, you know, you could reach other people and persuade them, use it as a model to persuade a different sort of treatment. That's certainly interesting. Another question?
So I am all for always connecting the community and the clinical world, since I feel like those are huge silos. I also sit on different committees for healthy neighborhoods. I do not see the needle moving the same way. There's still a lot of people that, you know, they're sitting at this table and we're sitting at that table, and there's not an intermixing, and really they talk about change but not implementing the change, right? And there's different stages, right? We're working through it and trying to get everyone there. But more or less, I was looking at the fact of how could we do this from a care coordination part, right? So it could happen at the education level where you're talking, but then it could also be the people that are coming into the emergency department, and if that doctor feels as though that it is an unnecessary or overuse, then they could give that information to, let's say, CareLink, which we have here, and then be able to do different care coordination where they can link it to the community, like a referral system like Delaware 211, and have that person who's able to then work with them, figure out what they need, and then link them to the different resources, and then have a hub for them, right?
Sounds great.
Okay. Sounds great in theory. That's what.
So what's the problem? What is it that people aren't really? Is it just like?
So there's the bottom line problem, right? There's also intellectual property, right? People, I've done this, I've done that, and the sharing different agreements to happen, right? Who's going to pay for all of this to happen? So there's a lot of different components, and I think that it's really easy to accept these different things when you say an African American man has a lower life expectancy, right? It's really easy to say someone who's poor or someone who has low education has this outcome, right? It's kind of like, oh yeah, we know that, right? But it's really interesting when you can flip this script to be able to show what you can do to that population, or what's actually happening in that population to actually make a real change.
Yeah. Do you think that some of that has to do with just saying, well, yeah, that is how it is?
Yeah.
Do you think that some of that attitude has to do with people's lack of familiarity and association with people who are not like them?
I think sometimes it's easy to be ignorant.
Mm-hmm. It's a privilege, really. Mm-hmm. Yeah.
Until you actually experienced it.
Yeah.
So in low-income country, I mean, I think the model of community health workers has been applied, quite often. Do you think that there is, you don't see the fear, as much fear in this context than you could recognize here in when there is this model that's working, community health workers with the community around?
No, I think that you do have the fear. because what's at stake is the things that make up the human condition. Love for other people, fear of suffering avoidance. So certainly fear still exists, but you're not burdened with a mountain of debt that your family's going to have to be responsible for in an emergency room if you're uninsured. So it's a different response to fear. Just like when he had insurance, he was able to use that fear to motivate him to go to the doctor. So I think certainly, it's part of, it's an existential anxiety of death. And that's part of the human condition. But, it's a solution that helps alleviate that for people, in my mind. Yeah, it was originally a concept from the 1950s with barefoot doctors in communist China, where 1 million peasants were trained in basic health care. And it made a huge difference in
Yes. Thinking back to that context of having a patient decide for themselves whether or not to visit the ED or any provider, have you, and I can't add too much to the conversation, but I know there is some work being done about fear of recurrence for patients who have cancer. Have you looked into that field at all, and the work that's been done?
No, that sounds interesting. No, I've just looked into...
I know some people get them, they're in the room, but...
No, I'd be interested in hearing, or just, a citation or author to look into that. That'd be...
Sure.
Yeah.
One thing you might think about in terms of the fear, especially with thinking of the guy with the headaches, is the actual interactions with the healthcare people and the reasons for them. Specifically, I wonder if someone comes in with a headache and they evaluate him and they say it's a benign thing, but then they also say, but make sure if you have another headache that you come back because you might be having a bleed then.
Right.
I'm not telling you that you're going to be okay forever. You're just okay today.
Yeah.
We have that very, we're going to counsel you on make sure you come back if there's anything bad because, you wonder how much that drives it,
Think how complicated that is. I mean, that would be complicated for any of us. And I think that people that don't have a background, you say something like that, what do you think? They take that in and understand what Dr. Vesey said?
No, I don't think they do. I mean, some people would, but, not, I just am doing interviews with people about diagnosis.
What do you mean? I'm afraid, I'm still afraid of it.
I mean, think about when you evaluate chest pain, they decide it's non-cardiac chest pain, but then you say, well, that doesn't mean you're not going to have a heart attack tomorrow, so.
No, I've said that 10,000 times. Every time I said it, I say, boy, that is a really rough one of life.
Yeah. And I'm just finishing a paper on diagnosis in the observation unit for chest pain patients with Dr. Rising, and people want a diagnosis, even though they don't know what the word diagnosis means. They want a diagnosis, and if they don't get a diagnosis, but they say everything is okay, that's still not good enough. Mm-hmm. For a lot of people, they want, you're not trying hard enough, or I'm gonna come back till I find out what's wrong. But that's definitely at play. Yeah, but it's interesting. A lot of your question, would they understand that? I mean, I was just interviewing somebody about diagnosis, and I said, well, doctors and patients, or doctors and nurses sometimes use the word diagnosis. What does that word mean to you? And he's like, I don't know what that means. And several people said that. And you'd be surprised, to learn a lot of people that you come in contact with can't read, and so those are important. That's part of that structural competency. Developing that.
Well, I guess that both sides are working off of different premises, right? I mean, you're working off of different logic models. In medicine, we're really based on the statistical thinking, where you say, incidences of cardiac disease are associated with. So you're really careful to not say one thing is causing the other because you don't really know. You can make a case for it, rule in, rule out, right? But you're talking statistical talk. And for folks who come in, it's probably, depending on their level of their background.
Yeah.
It's more of a white and black thing.
Yeah.
It's you have it or you don't.
Yes.
And I think there is also an assumption that in healthcare we know more about what's going in that body than we really do. So we're really working with completely different logical models and frames of reference that are completely different.
Yeah.
So talking across that barrier is very complex.
I just read an interesting book, and not just, but something that's coming to mind is a book called Diagnosis, or putting a name to it, Diagnosis or something like that, but by Anne-Marie Jutel, that you all might like to read. She's a nurse, she's an RN, but she's also a medical sociologist, PhD in medical sociology. And you're talking her talk. Yeah, you might like to read that, just in your practice and help people understand and interpret diagnoses. Any other questions? Well, thank you very much.